The title of today's talk is Treatment of Facial Paralysis and Synkinesis. And actually, I'm going to reverse these topics on you a little bit. My usual routine is to talk about synkinesis first, is to talk about facial paralysis first. But instead, I'm going to talk about synkinesis. And I have my reasons for doing that. I have, let me see here, no disclosures to make. Just make sure here. Great. So why begin with synkinesis? I think that for me, the issue is that synkinesis is the higher prevalence disease. Patients who present with facial paralysis, all comers. The most common cause by far, as we all know, is Bell's palsy. So of the 100 to 140,000 patients a year who have facial paralysis, we've got 50 to 70,000 of those are probably going to be Bell's patients. Most of those patients are going to recover. So the incidence of synkinesis, while it's hard to estimate and maybe we don't have great data on it, the incidence of it is likely in the neighborhood of 15 to maybe even 30% of patients with Bell's. There are biases depending on how those numbers are derived, but needless to say, these are patients who have only had Bell's palsy. They've got a great life expectancy. So the prevalence of this is very high, and I've been treating a lot of these patients. And I've found that I have refined my treatment algorithm for taking care of them. And so I wanted to transmit some of that information to you. So to lay the groundwork and the foundation of understanding synkinesis, I find that kind of a basic neurobiology discussion is good to do first. And it's very high level. We can really go down a rabbit hole with this topic, but I think in its simplest form, we can all understand it. So any peripheral motor nerve, it doesn't have to be just the facial nerve, but any motor nerve in the body, if it suffers injury, will subsequently undergo processes that we're familiar with as otolaryngologists. Wallerian degeneration will occur, metabolizing and clearing the way for the distal nerve so that nerve regeneration can then occur. And it does occur, it occurs robustly. Axonal regeneration is a process that I would say is sometimes harder to stop than it may be to start. Even though we treat paralysis and it seems like axonal regeneration would be difficult, axons robustly regenerate. They do so powerfully. The thing that they don't do is precision. They are not very or always accurate and precise about the destination to which they go to. And so in this simplified diagram that we're using, after injury, we can get perfect reinnervation like we've shown here, or we can get off-target reinnervation. It's kind of the Bugs Bunny taking a left turn on the way to Albuquerque or whatever. And so the wrong endoneurial tubule is used by the regenerating axon, and it ends up at the wrong motor end plate, the wrong neuromuscular junction. So you can see already just on a basic kind of axonal level, even though this is idealized, how we can get synkinesis. But that's not all. So after a nerve is injured, it's actually quite normal for there to be polyphasic sprouting of the axons. It's a little bit more common maybe in sensory nerves, but it happens in motor nerves too. Now, the body may prune or pare these down, but it doesn't always occur. So polyreinnervation of several different motor end plates by one axon can occur. So you can see on many levels from the biology of this, we're kind of hardwired for this problem to occur. I think the body would prefer a problem of a little excess but off-target reinnervation rather than less. So you can see though from the kind of very beginnings how synkinesis can occur. So when it presents to us clinically though, we know that what we see is the muscle movement or the mix of abnormal movement. And this is defined by Roger Crumley in 1979, and it's still a very apt definition of the process. That synkinesis is unintentional motion of one area of the face when you're trying to move another. For example, the eyes closed during smile, which my patient is here. And so as I'm counseling patients and getting them ready to understand what's going on, and then from that segue into treatments, we'll talk in broad terms about your efforts to use a particular part of the facial nerve to move the zygomaticus muscle. Instead, when you're attempting to do that, there's some nerve input because of the cross wiring that ends up innervating the orbicularis oculi, causing the forceful eye closure that you see exhibited in my patient here in her right eye. But it's not just that pattern. It can be, you can just shuffle the deck of all the names of the branches of the nerves, and you can have that pattern of aberrant reinnervation. So likewise, during the effort to smile and move the zygomaticus muscle, you can have forceful, sometimes contraction of the platysma. Even some of the lesser well-known muscles, it's possible for the digastric to be involved. That can be a painful process. So there's a lot of complexity and nuance, and the more I talk to these patients, work with them, and treat them, the more that this kind of opens up to me. So one of the topics I'm going to cover later, because it's increasingly popular, it's increasingly discussed, and used more frequently now, is selective neurectomy. I knew that this was an old procedure, so I went back into some of the historical publications and I tried to find the earliest publication that I could. Sorry, one second. Getting a text from a colleague and replying, giving grand rounds. So the oldest description of selective neurectomy that I could find had this quote at the outset. And it was a perfect encapsulation of something that I think is very important to the treatment of this disease. And it is that the treatment of spastic facial palsy, which is what they were labeling it, not synkinesis, but it's the same thing, it must be undertaken since it is permanent and a progressive disorder. The thing that leaps out to me here is that it is permanent. If you remember our little diagram, the illustration that we were just looking at, when the axon regenerates to target, to a motor end plate, even if it's the wrong one, it is home. It is there forever. So this is a permanent situation that this patient is dealing with. So therefore, it demands of us treatment for it. I think that when we take a synkinetic patient, sometimes next to say a patient with flaccid facial palsy, the synkinetic patient can look much better, but they can feel very subjectively affected by this, and there is real facial dysfunction there. So because of the permanence of this process, I really like that to kind of set the table for what we do for treatment. So the treatment algorithm that we use here is as follows. So, and I'll go through each of these incrementally, but just to give us a quick kind of walkthrough. After a consultation with me, where I make a diagnosis and make sure that they really had Bell's palsy, or that the etiology of facial nerve injury was as advertised and there's no indication for further imaging and all of those types of things. And I will say, the spastic spastic movement of the face can be a bit of a neurological phenomenon. You do have to be a bit careful and keep kind of your antenna up for things that might require a referral to a neurologist or imaging by you to get some workup done. So those are things you have to consider. But granted, we've made a diagnosis that the patient had Bell's palsy, now they have synkinesis. The first step for virtually all patients, I'd like them to undergo a course of facial neuromuscular retraining, specialized physical therapy, which I'll talk more about. That really lays the critical foundation for any future treatment and can be all the treatment the patient needs. So that really comes first. For a subset of patients, they then progress into chemodenervation of muscles that are firing at the wrong times using botulinum toxin. The broadening use of botulinum toxin to denervate malfunctioning, misfiring muscles in the synkinetic face, in my opinion, that has really opened the gateway so that we have discovered other very effective treatments through the use, with a fine guided eye, the use of Botox. That can be a treatment on its own, but it can also be a very useful guide for both the surgeon and the patient to understand what the potential role of surgical neurectomy or myectomy might be if it's a fairly severe debilitating case of synkinesis. There's a much smaller group, and I'll talk about the treatment algorithm and indications for treatment of this, but this is a bit of a talk in and of itself, but there's even a small percentage of patients who are really best suited for a gracilis-free tissue transfer for their synkinesis. Those patients are really unmasked by the use of botulinum toxin denervation, and we'll talk a bit more about that. Okay, so The first element of treatment, as I said, is wonderful rehabilitative treatment. And not all centers are fortunate to have somebody who is really skilled and talented at this. But Sarah Strandberg, she's a speech and language pathologist who many of you know. She is quite good at facial neuromuscular retraining. And so I encourage all of my patients to begin with either an in-person consultation, or now in the COVID era, we've been taking full advantage of video consultations with Sarah, which is great for patients who come to see me on consult, and maybe a return trip with a couple-hour car drive is tough, and they can see Sarah relatively quickly utilizing video, which I've been very enthusiastically using. So I can't do this. I can't do this complete justice because I don't provide facial retraining. But in trying to encapsulate it in a single slide, which may or may not be possible, this is a specialized form of physical therapy. It's teaching the patient as much what they should be doing and also what to avoid. You will find if you treat these patients, some of them suffer from a little bit too much effort. They're trying so hard to move that actually results in some of the visible dysfunction that they suffer from. So a guided hand to take them through how to focus on the muscles of the face, isolate the good movements, minimize the bad, that is extremely effective. So we want more functional movements. We want to decrease abnormal movements. And I think just an interesting side note is that I believe that the muscles of the face don't have any Golgi tendon organs. So you don't get a lot of proprioceptive or really any proprioceptive feedback from your facial muscles. Pretty much what you get from your facial muscles is the disturbance of the soft tissue, and that's kind of how you know what your face is doing in space. But unlike your biceps or your triceps, you don't have as much of a I kind of know where my hand is in space right now. That type of knowledge for the face is a little bit different. And so it just underscores that facial retraining and this kind of sensitization to how the facial muscles are moving is really critical. But from my perspective, the real key is that the patients become more sophisticated, able to provide me more accurate and specific feedback to what's working and what's not. They become experts at the movement of their own face. So one of the reasons I really like it up front is I feel like they're able, through training, to really isolate what our goals of treatment are. What are the things that they're not able to get yet? And what do we need to target with botulinum toxin? And then subsequently, perhaps with surgery. So in order to validate that this really does work, you'd be surprised there's not a lot of data out there. This is a commonly used thing. Facial retraining is pretty much, I would say, standard of care to try to treat somebody with synkinesis. But not a lot of studies have demonstrated the clinical efficacy of it. So in an effort to do that at our own center, we performed a retrospective analysis of just under about 200 of our patients. And there was a small subset who had undergone, with no botulinum toxin, no surgery, had completed facial neuromuscular retraining alone. And as some of you know, one of my kind of central hypotheses of facial dysfunction and facial paralysis is that it is a disease of communication. And I have a couple publications that explore the impact of facial paralysis and facial dysfunction on something called communicative participation. That's your willingness to just participate verbally with people you know, people you don't, different scenarios. It's an across disease metric. But to cut to the chase here, we found a significant improvement in patients' communicative participation when they had completed a course of facial retraining with Sarah. So you can see that the starting value was just under 15. It's a scale that goes from 0 to 30. So you can see an extraordinarily strong statistical effect. We also had an significant improvement in patient quality of life with a disease-specific instrument. And there's more data on the page, but I just wanted to highlight the really profound improvement in communicative participation. It's kudos to Sarah's great work with these patients. So as I said, though, for a subset, they may need botulinum toxin in addition to facial retraining. The former group that I just showed did not have that. And Botox has been shown in many studies to improve facial symmetry and significantly improve patient quality of life in those patients who have synkinesis. So as a patient is shown here, it can be used for better symmetry for sure, better movement of the oral commissure, and I'll talk about that a lot more in subsequent slides, but also improving facial comfort by reducing facial spasm that they're experiencing. Okay, now, as I'm coaching a patient through this, there's more than a small number that will say, look, I am not that enthusiastic about getting Botox injections, every 3 months for the rest of my life. And while that is true, and there's nothing that can completely replace Botox, I introduce the concept at this point that, look, botulinum toxin can be both a therapy, but it can also guide us. It can guide both me, the surgeon, and the patient into what muscles, when denervated chemically, exert a therapeutic effect. And it allows them to live with that. They walk around with that for months. So they become very well versed in what the potential result of a neurectomy or myectomy may be if they're guided by somebody who's experienced in those procedures. So for me, this is actually a critically important setup for how we're going to treat them. We use it both for outright therapy. They're welcome to just continue on with Botox. But then secondly, they can use this as a guide for further treatment. But many of my patients have a simpler question. They will come to me and just say, this all sounds great. I think I understand synkinesis now. Sarah helped me a lot. I understand there's, Botox is an option. Am I going to smile again? Because that can be one of the most debilitating things. Of course, there's all different varieties of kind of muscle dysfunction. The eye region could be most bothersome to them, but a lot of my patients are really focused on, will I smile again? So in order to answer that question, I explain to them that they have to understand that they're in a slightly unique circumstance. So a patient with synkinesis may not smile because they have a tug of war that's going on between the elevators of the modiolus, the muscles that are trying to elevate the upper lip and produce a smile, and those muscles that are the depressors that are in effect co-contracting and freezing the face, holding the smile down such that it cannot elevate. So this is a tug of war between the lip elevators and the lip depressors. So it results in essentially no meaningful movement of the modiolus. And so this is where botulinum toxin is very effective and a very useful tool in treating and maybe planning future treatment. And the strategy is a fairly simple one. If we use this analogy of a tug of war, what we're going to do is isolate some combination of the depressors and provide a chemical denervation that lasts for about 3 months, and then see if that can unmask some movement of the zygomaticus muscles that wasn't visible before because of the co-contraction. This is not as simple as 2 injections in those 2 locations. This is just a simplified diagram. In general, I believe that the closer that you get to the lip, the more dysfunction that you can have if you're paralyzing for 3 months. So you have to gauge the patient's risk tolerance. You have to do a very careful physical exam, and you have to explain to the patient that it is an iterative process, that you're going to be sequentially taking these muscles offline and seeing if you can find the right combination for them. So what we are doing is we are minimizing the impact and the power of the depressors to see if that can allow the modiolus to elevate during smile. Now, I had mentioned briefly gracilis free flap for synkinesis. This is for a smaller percentage of patients who have synkinesis, but if you see many of them, there are a percentage of patients that have synkinetic movement. You will see the lower lip contracting when they're not trying to do it, when they're doing other facial muscles, but they have a really hollow, really sunken and small cheek. That's a sign of atrophy of the zygomaticus muscles and some of the muscles that are in that area. So you have to have an extra index of suspicion that perhaps in this patient, it may not be adequate to denervate the depressors. Chemical denervation or surgical denervation isn't going to do a thing for somebody who has no power in their zygomaticus. You have to think a little bit differently for this patient and think about neuromuscular supplementation. And in my mind, the best candidate for that is a gracilis-free tissue transfer. But onto the more common scenario, what I want to talk about is how do we execute this concept of denervating the depressors in order to show a patient what a potential surgical result might look like, and then to execute a surgery that gives them benefit. So this is back to our index patient. And after a course of a variety of injections using botulinum toxin, we found that she got pretty reliable relief and benefit that was to her liking with treatment of the mentalis and the platysma. And better believe I injected the depressor anguli oris, I injected buccinator, I believe, depressor labii inferioris. So, we're going for, as much excursion of the oral commissure as we can. But you have to understand that some patients are not going to like the result of denervation of all of that perioral musculature. And so because of that, I really do like using botulinum toxin as a way of guiding both myself and the patient through what should we target if we were to translate this chemical denervation into a surgical selective neurectomy. So the plan is really guided by the Botox. And so we've already demonstrated efficacy that she feels a lot better when certain muscles are denervated. So the cervical branch and the distal portion of the marginal mandibular branch are both targeted in surgery. And so you can see her postoperative result with much less contraction, essentially no contraction of the platysma. I did a contralateral procedure as well, denervated and transected the platysma on the left. Much less, though still some dimpling of the mentalis, a better result, a more symmetric smile. And interestingly enough, for this patient, although she has oral ocular synkinesis, if you look at her before picture, the right eye is certainly closing. That does not mean that the eye is well lubricated and that the cornea is healthy. So patients can have excess closure with smile, but that doesn't mean that their corneal protection is very good, and they may not have normal tear film production due to the prior facial nerve injury and faulty reinnervation. She has a more central injury location. So to cut to the chase, we can't Botox her right eye. So this is her without Botox to the right eye. But in a successful case, the selective neurectomy can decrease the effort that a patient has to exert to get the movement that they do get. And that can calm down some of the contractions that you may see in other areas. That's not a reliable thing, but it's a noticeable thing and a notable thing, a very nice thing for a patient when they do have that. So that's no blepharoplasty was performed and no Botox injected in the orbicularis oculi. So what about other parts of the face? It's not just perioral muscles that can be targeted in this fashion. So you can use tried and true aesthetic techniques for your access to perform myectomy. As many of you know, an endoscopic brow lift, a good endoscopic brow lift will, as part of it, divide the corrugators and procerus muscle to relieve some of the frown lines that people may notice. And that's one of the goals of a good endoscopic brow lift. So in a patient like mine, who's shown here on the left, she's bothered by some of the periorbital contractions that she has. And for her, the corrugator is very bothersome. She's a very high functioning person, just as my other patient I showed you was. And sometimes a little bit of corrugator contraction with orbicularis oculi can really impart a completely different emotional state than the person is trying to convey. So we, over multiple rounds of botulinum toxin injection, demonstrated that we had good efficacy from the points that I showed there. So we followed that up with an endoscopic brow lift and a myectomy, releasing those muscles bluntly through an endoscope with incisions that are all hidden in the hairline. So as some of you know, the endobrow incisions are hidden kind of up in the hairline, so it minimizes the morbidity. There should be no scalp numbness from this procedure when done properly and successfully. And it can help give the patients a Botox-like effect and a relaxation of some of the synkinetic musculature. Okay. So as I said, the minority of patients, though, may require a gracilis for treatment, but I do think that there are kind of separate selection criteria. There's certainly a longer conversation that has to be had with patients, but increasingly I'm seeing this as a very viable option for patients with synkinesis who have no power of the zygomaticus that we can uncover through denervation.